I thought maybe I would cover a little bit of new material because, like we said on the first class, I feel like you guys are all my students, so this is a lot of fun now that we're doing this together. And even after COVID, I'd love to, if you guys want, we can do some other medical stuff, and I'm sure there's other people in the community that would want to do that too if Rabbi is interested in continuing such a series. But
For sure. And Gil, I hope you're
Sorry?
going to talk about. I hope you're going to talk about harvesting antibodies.
Yes, we can talk. So there's a lot of new material.
Okay.
And every week there's new stuff. So I know that Amy wanted me to talk about some positive things. So there is some very good positive news that's been reported in the medical literature and also in the lay press, and that is that there are at least 86 trials ongoing now to look for a vaccine, and this is unprecedented in history. And so I think that's really good news. And I think as the weeks go on, based on what I'm reading, I think that there is a good chance that we'll have a vaccine, maybe not for the next 18 months or 2 years, but a lot of new stuff around vaccines. And at the end, I thought maybe we'd talk a little bit about some of the ethics that were proposed by Dr. I think it's pronounced Leipzig at Harvard, who is an epidemiologist, and he has a pathway to fast track vaccine research. But let me just start with this, and then we'll do with Kimel's questions. Then, Rabbi, you can just signal when you want me to stop talking.
Okay.
So I wanted just to get something straight, because I feel like this is something really important, is about terminology. So there's two really important things to understand. When we're talking about the pathogen or the bug, it's called SARS-CoV-2, whereas the disease is called COVID-19. So I think there's sometimes people mix them up, but I really wanted our group to really understand that. So it's kind of like if you say somebody has pneumonia, that's the disease, COVID-19, and the pathogen in a standard bacterial pneumonia would, let's say, be streptococcus or whatever. So the bug is SARS-CoV-2 and the disease is COVID-19. So just if we're talking about vaccines, it's not really to COVID, it's to SARS-CoV-2. The other concept that I just wanted to review, which we talked about, but I just want everybody to really understand the difference, because it's a little bit in the lay press, is the difference between mitigation and containment, because they're really important concepts to understand. So the way to remember it is that when we talk about mitigation, those are the things that we really don't like not having parties, not going to the beach, not going on cruises, or for those that like cruises, not going to have family dinners. Those are mitigation techniques that prevent spread.
Hand washing.
Hand washing also. I like
Masks.
hand washing, but so masks, those are all mitigation techniques. Whereas containment is something very different. That has really been, the countries that have done an excellent job are really Taiwan and South Korea, where they identify with testing who has COVID, who has the infection, and then they contain them or isolate them, trace back all of their contacts, tell everybody to stay home. And so those two techniques, mitigation and containment, are ways that you decrease spread. So mitigation would work forever, but we'd all have to stay home forever. So society is not going to accept that, because there's too many economic burdens, mental health burdens, family burdens. There's too much distress to have to mitigate forever. So that's why when the next phase is really a containment phase in order to be successful. So I just want everybody to understand those two basic concepts. Now, one thing that's really important to talk about is, and I don't want to get too medically scientific, but I think it's a really cool thing to think about. And the business people on the line, I can try to do a little bit of analogy so you can think about it. So it's in medicine, when we see a patient that comes into the hospital, before we do the test, we try to think of a pre-test probability. So why is that important? Why is it important when somebody comes in with, let's say, a cough and a fever? Why is it important that we classify that patient on paper or in our heads as low, medium, or high risk? Because let's say somebody comes in and they tell you, look, I was just in Italy. In my house, there's somebody from Wuhan, and I have a cough and a fever. It doesn't really matter what the test shows. That person's at such high risk that even if their nasal pharyngeal swab is negative, they still have to be isolated in hospital, because you wouldn't trust a negative test. But if somebody's extremely low risk and they tell you, well, I haven't been out for 2 weeks, I have had no visitors, I've had my food delivered, a negative test for them is much more helpful. So, so it's very important to think about that. And that's why when we're doing testing, it's very important that you talk to your family doctor, or if you go to one of the test sites, that they record those history questions. Where have you been? What's your travel history? Who are you a healthcare worker? Are you working in a grocery store? All the high-risk activities that help classify the person's risk, and then the test is much more helpful. So it'd be kind of like, just for the business people, like let's say, just use an example, let's say you are a landlord and you have met the potential tenant and you already have determined in your mind that this is not going to be a good tenant, then it doesn't really matter what their letters of credit or the bank tells you, because you're not going to even look at that if you already think that they're, you'll qualify those other features based on what you've already decided. And so people that just maybe look at what the bank says, that may not be the right thing. So, and we try to do the same thing in medicine. We try to think about what the risk is and then look at the test for confirmatory features. So I think a positive test. So now let's talk about the test just for a little bit. I know we've talked about this before, but I'm sure there are some questions. So the nasopharyngeal swab, that's the test where they put kind of like a Q-tip thing into your nose, take a little bit of sample, and then send it off to the lab. And that's a reverse transcriptase PCR, which amplifies a virus. So that test only looks for active virus. So if you do that test, is there a possibility that the test tells you that the patient is negative or doesn't have the virus, but they really have it? Yes, because it's not 100% sensitive. So only about some labs say 90%, some labs say 80%, and some labs even say 70%. But let's say it's 80 to 85% sensitive. So that means that there's a certain number of people that either they don't have enough virus load, or the sample wasn't done correctly, or for whatever reason, they're not picking up all the tests. However, if the test is positive, it's very, very likely that the person has it. It's very, very specific. So just something to think about. Now, what about these other tests that they're talking about in the news, serology? That's a totally different thing. And that is done by a blood test, so not a nasopharyngeal swab. And in that test, we're looking for antibodies. So it's the body's B cells that produce antibodies against the pathogen, against SARS-CoV-2, to use our new terminology. And antibodies come in different varieties, but just understand that after a week of infection, 7 days, you produce one type of antibody, and about 10 days later, you produce another type of antibody. And those antibodies are helpful to show that you've been infected. Now, does everybody that's been infected have an antibody? Not necessarily. And so it's not 100%. So when they talk about it in the news as being the next panacea, I think we have to use caution. Right, Charlie? Yes. So now, so just to move on, and I just want to just cover one more concept. I know that we don't have too much time, but I just want to review again the concept of the R0 or the R0 that you're going to see a lot in the newspaper. And I think we talked about it in the first class, but I just wanted to go over it again. So it's a really important concept to understand, and it's very straightforward, but it's not that well explained in the literature, or in the lay press. So what it means is, just think about it as the ability of the virus to spread. So to give you an idea, SARS-CoV-2 has a reproductive, or an R0 of about 4. So what does that mean? That means that if one person has it, they're expected to give it to 4 people, assuming that the population they come in contact with have never had it, are not vaccinated, and have never been exposed. And so every person that gets it are expected to give it to 4 people. Now, how does that compare with other viruses? So measles is 17, which means it's much, much, much more contagious. The regular flu is about 1.4. So just to give you an idea. So why is that important? The reason why it's important, Charlie, is because the higher the number, the harder it is to contain. So SARS-1 back in 2002 had a R0 of 1. So it wasn't as contagious as this one. This one is about 4 times as contagious. So how do we get the R0 down? Because if it's at 1, then the virus will stay in a steady state until people have enough herd immunity for it to go down. So how do you get it down? Well, there's a few ways. You can vaccinate everybody. You can have herd immunity by people getting exposed and getting immune to it. Or you can do containment, which is why I think improved testing, like we touched on last time, is really important. So now, for those people that really like math, and I won't spend too much time on this, but
I'm going to interrupt because there's a question about one of those approaches is the herd immunity. I'm curious what your thoughts are on the Swedish model of get to herd immunity by not shutting down.
Right. So very good segue. So herd immunity in Vancouver is virtually certainly impossible at this moment. I would be very surprised if we tested everybody, if the positive rate was more than 2 or 3%. Now, just to give you an idea, in the state of Massachusetts today, it was announced that of those that have been tested, 25% of the tests are positive. So why is that? It means that the people that are going to get tested, they have a high pretest probability, like we talked about. A lot of those patients have symptoms, so 1 in 4 are actually positive. Whereas in South Korea, it's much lower. It's about 3% because they're testing a huge amount of people. And so the more people you test, the lower that number is going to be. So the lower the number, the better. Now, I think that in BC, and this was also discussed with Dr. Onrot, who's one of deputies of my colleagues, who some of you may know, I think we got really lucky in BC. We had the later spring break. We didn't have a lot of large gatherings. There was no sporting events, et cetera, et cetera. So that's why I think that the asymptomatic transmission or the underlying exposure in BC is probably low. But the only way to know that for sure is to do a lot of testing. So I think that the science would really say that the more testing we do, the safer we can be to reopen the economy. Because if we reopen the economy now without a containment strategy, in other words, if we reopen the economy without doing a lot of testing, then it will spread and it will flare up because we won't be able to identify those that are asymptomatic spreaders, which are really the people that are putting other people at risk. So I think that we can think about reopening the economy, but only when we have a good strategy for testing, and not only testing patients that have severe fevers and shortness of breath, but also those who are asymptomatic, just like they're doing in South Korea. And I think that we shouldn't think about it too much because South Korea is having tremendous success with their pathway. And you can look in the newspaper, they have these little phone booths that you go in, they're sterilized every time, and they ask a few questions like our pretest probability, then they do the test and the person goes on their way. And if they're positive, within 24 hours, they track down all their contacts. Those people are asked to stay home and life goes on. And so that is really the most successful way to bring down that R0. So there we've combined a lot of concepts into one. We reviewed the terminology. We talked a little bit about the difference between mitigation and containment strategies. We talked about why it's important to do a lot of testing. And the only way for us to reopen the economy with confidence and to reduce our risk of having high mortality rates, and kind of like the way Rabbi Rosenblatt's getting at, with Sweden, if we didn't do a lot of testing and if there's no mitigation strategy, then yes, eventually herd immunity will build up, but we'll have a lot more fatalities and a lot more morbidity and a lot higher risk of strain on the hospital system. So that's why it's a risky strategy. Now, what they did in Sweden, which Hoodie also asked us to touch on a little bit yesterday, was that they asked people that were over the age of 65, if I remember correctly, to kind of stay home. Personally, I don't think that's so cool. I think that people of all ages should be able to resume normal daily life together, and that we all have a responsibility to protect each other. And then maybe I'll just segue a little bit just to talk about a very interesting paper that came out today from New York, from JAMA, where they looked at now this is not such big news, so I'll just pre-warn you, but just to remind us about why I think that a very careful, deliberate approach to reopening the economy is really important. So they looked at 5,700 people that were hospitalized in New York. So North Americans, 5,700 people that were hospitalized. So these are not patients that had mild disease. They have all been hospitalized. So what did we find? What are the key characteristics of those that are hospitalized? About 60% were male. The average age was 63. And the three main risk factors, which is consistent with other studies, is hypertension. More than half had high blood pressure. 42% had obesity, and 34% had diabetes. And of those patients that were hospitalized, I think it's important just to point out that 12% required mechanical ventilation. And of those on mechanical ventilation, the fatality rate was quite a bit higher in New York than we saw in Italy. So again, just a warning that if we're going to open the economy without a containment strategy, then those people who are at high risk based on these criteria, I think would have a high. I don't think we should think that our mortality rate in BC would be lower than those in New York.
Is
However, I
Sweden
could be
going to be
wrong. I also thought
is
that we would
Sweden
have a
going to
lot
be a
more.
bloodbath then?
No, I think if it was up to me, what I would do is I would just follow the South Korean model. I would say we should have testing centers available downtown, at Oak Ridge, at the airport, in East Van. People could go with or without the symptoms, be tested, and if you're negative, great. There's a high chance that you don't have the disease. Remember about that proviso that there's a certain false negative rate. But if you had it, then you would be told to stay home and people would comply with that. And then the chance of that R0 going down would be very good. So I think that's the proper way to do it.
So I don't think we know. And if we're going to be clinicians or doctors or scientists, epidemiologists, thinking about what to do in terms of before we open up the economy, and you asked either last week or a few weeks ago, are you going to be giving your sermon in Rosh Hashanah in front of the synagogue? We can't answer the question because we need to know. We need the science. Like we don't make decisions about medications without the clinical trials. Well, we also can't make the decisions around, is it going to be a bloodbath or not, without knowing. And the only way to know is to test and see what's out there. Is it going to be, and the only way that we can really have a good percentage that we understand is if we have a big denominator of testing. If we have a selective numerator and denominator, then that's not going to really be reflective of a good containment strategy. So I don't know the answer to what will be.
Someone once said to me, if my bubby had a beard, she'd be my Zadie. So the issue is, I heard Governor Cuomo say that they're running every machine in the state 24 hours a day, 7 days a week. And they're still, and they have run higher per capita capacity than anywhere else in the world. How far are we just from a real, practical level of being able to get to a South Korean style testing? It's great. We can test everyone, and I would love to be there. I just don't know if that's something that's actually going to happen.
Well, it's a good question. I think not everywhere in BC has equal testing facilities. At St. Paul's, like we talked about, we have the capacity to do up to 4,000 tests per day on a state-of-the-art machine with state-of-the-art trained technicians. We're doing far less than that, which may or may not be public knowledge, but we are not using our machine to the maximum capacity. So all of the clinicians that we're in touch with really feel that we should be optimizing that. So I want to open up the question, but I just want to give one more concept, just because I think that this is really important too. And
Gil, at that capacity, St. Paul's capacity,
like how far
it's 150.
That's really a question for public health. Like if we're able to, because we can say what we would like. Gil said, I would like a strategy where we're doing more tests, but is that possible? Well, it's possible in Vancouver, possibly, but is it possible throughout British Columbia?
Maybe not.
Well,
wait.
I don't know.
I'm going to throw some raw numbers. A couple of years ago, they said the population of Vancouver proper, not including Richmond, Burnaby, etc., Vancouver proper is 600,000. So at your current testing capacity, it's 150 days before we can test everyone.
Right, but we could extrapolate. So if we did 2 weeks of maximum capacity, if we tested 50,000 people, that would probably be good enough for the mathematicians to give us an idea of the R0. That's what we need, that number.
I see.
Then we understand how contagious, like in our local population, how virulent it is. Because obviously in New York, the infectiousness, the R0 is going to be different. The R0 is going to be different than it is in BC.
Because of strains, because of the subway, because of all those things.
Exactly. So we need to know our R0, and then we could reopen the economy with confidence. But I thought maybe just one tiny little thing. So like when we think about HIV, when it first came out, when it was first, reported in 1981, the the R naught was really only relevant for a certain patient population that had those risky behaviors. So for COVID, the risky behaviors are really things that we like to do, like be together and social gatherings and sports, and so those are the risky behaviors, and that's how it flares up and that's how it persists. And so the R naught is really must be qualified when you're thinking about which population it is, because different diseases have different abilities to propagate. And so the problem with SARS-CoV-2 is that it's infectious by breathing, it's a respiratory contact. It's which is really what makes it dangerous, and really why we need to take it seriously, and really why we need to open up the economy properly. And there was an interesting talk from JAMA, also by Dr. Walensky, who's the head of infectious disease at Mass General. And she said, that they don't really agree with opening up the economy in stages, because she said it's kind of like having a peeing section in the pool. Obviously, it's going to spread throughout. So that doesn't really work. You can only do it once you have a containment strategy in place. And that I think would really apply to BC. So we want to stop mitigation. We want to stop forcing people to stay home, but we have to have a strategy to increase testing, and also a backup plan such that if there are clusters that emerge, how we're going to do maybe local mitigation or things like that. So I think those were the main things that I want to talk about. There were a couple of other things, but I thought maybe we could do some questions. And
Yeah,
also,
I want to hand it over to Kimel now, who is our interviewer in chief here.
Okay.
So there's a few questions that have come in about the strains of COVID. So we're talking about a vaccine and, hoping 18 to 24 months, we see a vaccine that could possibly, work on all strains, some strains, from what we've heard, or what people are hearing in the news, that is it possible that New York is being hit by a stronger strain than we are here on the West Coast? Can you elaborate on that?
So there is some genetic analysis of the main strains that were found in New York, and they feel that it most likely originated in Italy, not necessarily from China. And so they think that what's happened, the strain in New York is similar to the one in Italy, but there's no real evidence that the different strains are different. Now, the one thing that I will say, which is also positive news, to go in for Ami's request, is that it appears that if you look at other pandemics, usually strains, when they mutate, they actually mutate to be less virulent and not worse. So they actually become easier, less pathogenic, which is a good thing. So and some of the scientists that I've been listening to have been saying that with summer coming, which they are hypothesizing there may be a 20% reduction in transmissibility, because it appears that this virus really likes cool, dry air, because when it's moist, the virus can't float around in the air because there's so much humidity that it falls to the floor. And so that's why the flu is less contagious in the summer months, and also people tend to be more outside. So those two things will hopefully reduce transmissibility by 20%. But I think it would be inappropriate to think that in the fall it won't recur. So we have to, in Canada and in BC, we have to have a plan for how we're going to reopen the economy, what we're going to do in the fall to contain it, and how we're going to manage also in patients that have co-infections with standard flu and maybe with COVID or other infectious processes. And so in the strain question, I don't know. I'm not an expert in that. I don't know how many strains there are, but if you want to talk a little about vaccines, there's a few pathways. So if we think about common vaccines that everybody gets, the MMR, the measles, mumps, and rubella. So how does that vaccine work? Well, that vaccine is what they call a live attenuated vaccine. So it's a virus. It's the actual virus that has been impeded. So it can't cause infection, but you're introducing it to the body, and then the body's army cells, if you will, say, wow, this is not a nice invader, so we're going to make antibodies for it. And those antibodies are extremely effective if you're exposed again. In fact, for measles, it's extremely effective. That's why that type of antibody response is so robust, much better than the mumps. Unless I got that wrong. No, but I'm pretty sure. Yes, I think that's right. I think I'm 99% sure that's right. That measles is a much better response than mumps. And there's other vaccines like for hepatitis B where they actually just produce a part of hepatitis B, a little protein that's actually produced in the lab, and they inject it into you, and then your body recognizes that protein, makes antibodies against that. So if you're exposed to the real hepatitis B, you have the antibodies together. So there's different pathways for vaccine development. And I think, of those 86 trials, I'm really hoping that they're going to have one that really works. But like we touched on last time, the key thing with a vaccine is safety. We do not want people that get the vaccine to have enhancement of the infection if they get it, which did happen with SARS-1. So we have to first test safety. And number two, we have to make sure that it's effective. So that's why it's a slow process. Now, the one interesting ethical point, and I'm not sure if there's an approach to this from the Jewish point of view, the Jewish law point of view, but one of the researchers, and this has been coming up quite a bit in the literature, is that some researchers are saying that to really develop a vaccine faster, if they had 100 healthy volunteers that are young, that have no medical problems, they can get the sample vaccine and then be exposed to real virus. And then you'll know fast if this works or not. And so some of the epidemiologists are really recommending that because they think that if you do the standard phase 1, phase 2, phase 3 of vaccine research, a lot more people need to be exposed, like in the thousands as opposed to 100. So maybe that's better from a societal point of view, especially if they have volunteers, just like some people volunteer to be in the army, or some medical students now are getting licensed a little bit early so that they can come work with these patients. And so it may not be unethical, and already 1,500 people emailed the Harvard professor to say that they'd be willing to sign up. So these are patients that are usually under the age of 25, between 20 and 25, that have no medical problems, perfectly healthy, and are willing, because their mortality risk is so low, they're willing to be get the vaccine and then be exposed to the virus. So something to think about, but that would really accelerate the chances of whether knowing it's safe and also efficacy.
I think the answer to that question on an ethical basis would depend on what the statistical risk is for that age profile. So, if the statistical risk for that age profile is less than, let's say, eating sushi, right?
Right.
Which has a small risk involved. But people are very willing to assume the risk of eating sushi for the pleasure of sushi. So
Right.
therefore, you can, generally speaking, the way Jewish law works on these factors is it would depend on what the standard of acceptable risks are generally in society. And that's somewhat quantifiable. There's another very interesting, I'll see if I can post a link in the chat. There's a very interesting, I listened to this episode of Planet Money where they there's an individual who, for the US government, quantified the value of a life based on risk assessment. Because if you're a firefighter or or someone who builds skyscrapers, you accept a larger level of risk than, let's say, somebody who works for I don't know, Stats Canada, right? So those are you're paying a premium for that, and the society has that. But I'm getting a little bit off on a tangent, so I'll let you go back to the COVID science.
Maybe just one more thing, because I think and then we'll go back to Kimel. But just one more also good news point is that, again, the evidence is showing, and this is also in New York, the children are really not getting badly affected. So the infection rate is very low. The mortality rate is extremely low. And we're talking about children is defined as those under the age of 16, extremely low. And in fact, there's some areas in the world where schools are open because the parents are healthcare workers or workers in essential industries. And in those places, when they see a family that has an infection, it appears that the child wasn't the one that was the index case. So in other words, they didn't cause the infection. So again, that is a really reassuring, because most of the flus and other things really affect children. So so maybe that would really speak to the potential for opening up schools with confidence too, because it appears that even if they get infected, they may not be transmitting it to others. And the fact that their mortality rate is extremely low is also very reassuring. But I think those were the key points I wanted to chat about. And if you want, we can do some questions if we still have time.
I have a question. Do you anticipate that the second and third wave to be worse than what we are seeing now?
That's an amazing question. I have no idea. Hard to know. Like for SARS-1, remember it started in the fall of 2002. By the summer of 2003, it was done because the infectiousness was so low. So I think that if we can keep that R0 low, and now that everybody understands that, if we can keep it low, then the chance of transmitting it is low. That's really the key point. But nobody knows if it's going to reemerge in pockets, and especially in long-term care facilities or prisons or things like that.
Or opening up of the borders.
Exactly.
Okay, I think the last question that we had, I'm just going up a little bit. The question about whether men were more at risk than women, and why is that?
Nobody knows, but they are in Italy, China, and New York, Seattle. All those key centers all are showing men have higher risk of infection, higher risk of going to the ICU, higher risk of requiring airway support, higher risk of death.
Is that even when you control for hypertension, diabetes, obesity?
Yeah.
I also just want to put out there, if anybody has a question for Dr. Rosenblatt. She, I believe, is still with us, at least so the Zoom would indicate.
I think we're done on our questions on our end. If there's anyone else.
Yeah, I have. Yeah. Well, I'm going to just ask one question for Gil. Gil, can you talk a little bit about this idea of harvesting antibodies and then reusing them?
Like the convalescent plasma therapy? Yes.
That's
the cool thing. Yeah. So we reviewed a couple of papers this week, actually, with one of our colleagues, with Dr. Hadla from St. Paul's also. So this is the thing. So let's say somebody gets the infection and they recover. Well, then presumably they have antibodies in their blood. So the idea is you do a blood draw and you collect those antibodies, and then you can give it back to somebody else. And this therapy was done in the 1918 flu pandemic. So it's more than 100 years old, this therapy. And it makes sense. And the two studies that have been done that we looked at were very, very small patient populations, and we couldn't really draw any conclusions when we look at it from a purely methodological point of view. Even the paper that was published in JAMA, which is a really great journal, there were some features of the study that, it's not a controlled study. So it's not as if they took they made a controlled trial to see if there was a placebo effect. But it appeared that it really helped in terms of dropping the fever, preventing patients from requiring airway support, and that those that required airway support got off the machines a little bit sooner than they would have been expected to do. And they tried in patients of young as 30 up to the age of 60, but it was a very small study. So convalescent plasma therapy is an old technique, but it does make sense because you're harvesting the antibodies that person produced against the virus, and you're giving it back to somebody with the hope that it'll help them. Now, some of the difficulties are that you really only can do it once per patient. So you have one patient that's cured can only treat one other patient, so it's very cumbersome, and also so it's not a very practical thing. What I think is more interesting is to actually maybe look at the antibodies to understand the structure of the antibody to help with vaccine development. And I think that that may be one avenue that might be useful. But I'm not an expert in that, but that's what the two papers that we looked at showed.
Okay,
So it's potentially promising, but cumbersome. Yeah.
Camille, you have any other further questions?
Yeah. I have one question about just going back to herd immunity. Israeli doctors are talking a lot about what is happening in Bnei Brak and how they're a great test case for herd immunity and what we should do moving forward. Can you comment on that?
I'm not sure what happens in Bnei Brak, but the herd immunity question is very easy to think about. So the equation is that herd immunity is equal to 1 minus 1 over the R0. So it's 1 minus 1 over R0. So as the R0 is higher, so let's say for measles, or for, let's say it was 100, let's say each person gives it to 100 people, well then the herd immunity has to be very, very high. You need almost 100% of people to be exposed for there to be protection. But if as that R0 goes down, then you need less and less percent of the population to be immune in order to acquire herd immunity. So does everybody get that? Maybe I'll just say that again. As the disease becomes less infectious, less transmissible, you require less of the population to be immune in order to acquire herd immunity. So the numbers for SARS-CoV-2 are looking like it needs to be somewhere between 70 and 80% to acquire herd immunity, meaning that if 70, 80% were either vaccinated or exposed and cured, then even if there were some positive people lingering around, those other 20% wouldn't be at high risk because the chances of them being exposed and those other 80% are not going to transmit it to them. So that's why it's low risk. If 70 to 80% of people had herd immunity, but we're virtually certain that that's not happening in BC, because otherwise our mortality rates would have been much, much higher, right? I think there's less than 90 people that died in BC. So we know that based on the mortality rates from other countries, we would have had a lot more people that would have died if we would have had anywhere near that number of exposure. So on the one hand, we were lucky because we mitigated it fast. Not a lot of people got exposed, but on the other hand, we can't just open the economy and let everybody go back to full power, because then our mortality rates will really go up, and especially our seniors will be at higher risk, so, and our healthcare systems. So I think that that's why the containment strategy, opening up the economy with a deliberate pathway and having testing widely available so that those that are positive, we can contain them and prevent spread, and that's how we get the R0 down, and that's how we get the herd immunity requirements down. So I know this is a little bit mathematical and medical, but I just want people to understand that why we're talking about testing, because I feel like some people, they say, Gail, why is testing important? Like, why would we know that there's only 14 new patients or 15 new patients that are being tested positive in BC per day? So why would we want to test more? Like, how is that helpful? So that's the reason why, is because we can contain them, isolate them, trace back their contacts, and prevent further spread. And that's how you get the R0 down.
Just one other purely medical question. Our first installment, the evidence was that asthmatics were not at a greater risk. Has that changed?
No, it may be. It's interesting that you asked that question. I mean, in this study, it was not a risk factor. The one other thing, just talking, so in China, for sure, smokers had a slightly higher risk. In BC, I think the smoking rate is going to be lower than in China and in Italy. I'm not as sure about that, but one interesting thing about airway, and Andrew Merker shared this with me today too, and it's really becoming very important in the literature. So patients that were coming into the hospital and that were having hypoxia, which means low oxygen in their blood, because normal is 100. So let's say the person was at 80. Well, that's really dangerous. But what they would do is they would bring them to the ICU and put a breathing machine in fast. But what they found now was that actually we should only putting the breathing machine in when patients start to lose level of consciousness or are really under respiratory distress, because this is not like the standard ARDS. And I actually think it's not really ARDS, which we introduced in the first class, but this is a pneumonia where the lungs are very soft, so they're compliant and easy to expand and contract, which is different than other acute airway disorders where mechanical ventilation is required. So what the new pathway is that when somebody is very hypoxic and they're starting to get a little dizzy and lose level of consciousness, and no longer, as they've been calling them, happy hypoxics, which means that the patient doesn't really appreciate how bad their oxygen saturation is. If they're able to be like that, then we should just give supplemental oxygen, tell them to lie on their front because that helps the lungs aerate and helps improve oxygenation, but we should not be quick to put the breathing machine in. And that strategy has certainly changed in the last few weeks in Vancouver and has changed all over the world. So this is widespread literature that we were trying to really reduce the speed at which we intubate, because there appears to be damage done to the lungs in terms of barotrauma, because that air pressure can really damage the lung when all we really need is high flow oxygen without the actual breathing machine in the airway causing pressure changes.
For the asthma question,
yes.
The Canadian Thoracic Society is updating guidelines every couple of weeks. As of now, it doesn't appear like asthma is an increased risk to get the infection. We don't have enough data to say yet if asthma puts you at higher risk if you have it. We don't know yet. There's not enough asthmatics who have gotten it to know if it's an increased risk factor for sickness.
I think, maybe the one thing that we can, last thing is that I think that, continuing excellent hand washing, wearing masks when you go out, maintaining social distance, those are all really important strategies. And maybe in the future, Delta just announced that for the airlines, if people want to fly, all the middle seats now are vacant. Air Canada is announcing that you have to wear masks on board. I think that those are good measures because they will reduce contact, and also wearing a mask reduces your frequency of testing your face. And there was even one short paper about, well, what about wearing those face guards? Because people that have hearing impairment, they can't see it's harder for them to hear when they can't see the person's mouth moving. And so that's been shown probably to be just as good as a surgical mask. So interesting, all these interesting things are coming up. It's only because more data is coming in. But again, the disease is only 15 or 16 weeks old.
And just to touch on the B'nai Brak comment, or on like England's strategy in the beginning of just go outside, have fun, and let's see what happens with herd immunity. That's at the expense of increased burden on the hospital system and mortality. And so, yes, it's correct. In Vancouver, in BC, we aren't going to have the herd immunity at 70 to 80%, but as a result of that, we're also having we've had a good mitigation strategy. We haven't put a burden on the healthcare system, but in the end, that whole thing about how do we reintegrate into society is going to be a concern, because we do not have herd immunity and we don't know what's out there. So we don't know what we don't have the containment evidence yet. So we don't know what's could come. And that leads to going back to if just to bring it around to Sorel's discussion, that exhaustion phase, right? Where we've had a heightened alert, we've been on alert, we've been, we're having coping skills, but how long is this going to be? And I'm not making any comparisons with any other places in the world. I'm not saying one is better than the other in terms of outcomes, but we have less certainty in BC because of that, and that may lead to exhaustion on our parts because we're nowhere near herd immunity. We don't know what's to come. We don't know when there's going to be another wave. Until we have more information about the R0 transmissibility, we won't know about our herd immunity needs. And the vaccine is, not anywhere near at this point. So lots of uncertainty in BC.
We have just a couple more questions that are coming.
Sure.
If you don't mind. I mean, I guess those who are tired can head off. But I think if you don't mind. So there's a question about hypercoagulability situation and use of anticoagulants.
Yeah.
Do you have any comments?
Yeah, it is increased for sure. There's been some cases of patients that have had hematoma, so bleeding inside muscles, increased bleeding, increased clotting. But that may not be specific to this virus. It may just be a feature of sepsis, and which we see in patients that are really, really sick. So again, I'm not a hematologist, I'm not an expert in it, but definitely in the literature, there is a higher risk of clotting and of bleeding.
Thank you. And one other question was, is the healthcare system worried about children who contract regular RSV in the fall, who need, ventilators and to have all the material ready? Are we worried about stock, and are we prepared for, just the regular viruses that come with the winter, and then the elderly population who could potentially be getting the second wave? Is BC preparing for that?
It's a very good question, and the person, Dr. Walensky from Harvard, addressed that. So she says, how in the past we used to talk about, flu season's coming, it's November. Well, now it's going to be flu season, COVID season, and RSV season. It's going to be all, or other infectious pathogens for that population are going to be all in one. And I'm not a pediatrician. I'm not exactly sure what's happening at BC Children's, but I'm sure that's part of their strategy to make sure that they have the right equipment, the right PPE, and good testing strategies. But again, the children, every center that has been looking at it, the mortality rate for children is extremely low, and a lot of children that get it are almost completely asymptomatic. So again, that's all positive news.
That's great, thank you. Those are all the questions that have come in for me tonight.
Okay.
Well,
Yep.
That's great. Well, thanks everybody for joining me.
Sorry, there was one last question. A question about nicotine patches.
In terms of what?
That it can be that it can help. Where did it go? It's gone. That it is stopping. That it's blocking.
New data shows smokers more immune. Looking for nicotine patches of healthcare workers. Data from China and Italy suggests that nicotine attaches to cells to block the virus.
Yes.
I haven't seen that literature. All
right. Well, you got some homework then.
But don't smoke. Smoking is really bad. Anybody that's smoking should. Okay. So I'm going to be telling you this off. But one other thing.
I reminded him of something else, so he's going to start talking.
Yeah, exactly. But again, the one thing that I always like to close with is just to remind everybody that food insecurity is still a problem in Vancouver. It's still an issue in our community. And so please remember to talk to Kimel. We're delivering food packages. It's part of the show program. JFS is working on that. And I think we need to really be cognizant of that. And the other thing that I thought was really interesting from a societal point of view that Dr. Walensky and her colleague that wrote one of the articles said is that, isolation is a privilege because not everybody can isolate and have access to a safe and warm house and also food security. So just something to consider that we need to really be aware of our other societal problems in BC and make sure that we are generous and make sure that people are provided with food and think about our food banks.
Just from Anna Wallach, who is a GP. Anna, I don't know if you want to unmute yourself and just talk a little bit about Sweden and nicotine.
Hang on. There. Did that work?
Yeah, that worked.
Hi, Gil. Hi, Debbie. So sorry to interrupt, but the thing with Sweden, like basically from what I've been following is they talk about how the mortality in Sweden compared to the other countries in Scandinavia is up to 10 times worse in Sweden than in all the other Scandinavian countries that have locked down. And Sweden is still showing the cases are spiking, whereas as of I think yesterday they were saying that Norway is already starting to come down. So following the Swedish model, people are still not all hands on that. That's the first one. The second one was the one about the nicotine study, and I literally just read about this afternoon, where what's happening is there was an observational an observation made out of China where they showed that something like 12% of the COVID positive patients were smokers, and they were looking at that as that being a smaller compared to the larger smoking population in China. So the theory is whether they were theorizing what is it in the smokers that is making it more protective. And I think there's a study that they are trying to think about in France, where they are possibly maybe testing nicotine patches on healthcare workers. But the main advice that is coming even out of France is not to take up smoking, not to start nicotine patching, not to do anything yet until we actually have data, as opposed to theoretical, maybe we could make this into a study. We don't really have any data yet.
Absolutely.
Yeah.
The same thing happened with the hydrochloroquine. It has not panned out. It has caused more arrhythmias, and it's caused a shortage of medication for those that have lupus. So we need data before we make these medication decisions. I would say that if smokers had a benefit, maybe it's just because their blood was more toxic, or maybe the virus couldn't bind as well in the nasopharynx, something like that. There could be some other reason. But I have no idea. I have not seen that study. So thanks for adding that.